I will say an important um, sort of thing to mention is that we have ongoing prospective clinical trials now at the Cleveland Clinic asking the question whether these preclinical or laboratory-based findings are going to be important or translatable into patient care in the near term. And so we're really taking a bench to bedside sort of approach here, where we have discovered these molecular alterations, these transcriptomic and genotypic features of cancers. We're using and developing novel radiotracers for imaging, for clinical imaging, and looking at genetics of patients that might determine what type of cancer they develop and whether or not that cancer will respond to a particular treatment. What we want to do before what we want to do is be able to take these findings and use them to better care for our patients. And that requires prospective study. That requires clinical trials. We really need to have the best quality evidence before we start basing clinical decision making around this. And so we currently have several studies open, one of which is a registry for HSD3B1 in patients receiving hormone therapy and radiation therapy to validate this germline allele as a potential predictive biomarker of response to treatment. We're looking at a PET radiotracer, again, 18F chlorpharabine, as a potential predictor of response to cytidine analog chemotherapies. And we have trials opening looking at the combination of radiation therapy and targeted therapy like antibody drug conjugates in bladder cancer, as well as looking at other combination therapies in prostate cancer. And so what I would sort of finish with is that I think it's critically important that we support clinical trials, that we continue to put resources and effort into investigator-initiated studies and early phase studies that really sort of are the engine that define the next generation therapies that will ultimately help us reduce the burden of cancer in our patients.